is we're going to have a little talk about deciding on the right fertility treatment, a comprehensive guide. So the reason why I decided to choose this topic is because fertility, there's so many different types of fertility treatment out there. And what works for one person may not necessarily work for another. So to decide on what kind of fertility treatment that you think that you would want and whether it's suitable for you, we need to go through a few things. So I hope that we can, go through a lot of it today, and we'll take some questions a little bit later. Okay. So I'm consultant ONG and a fertility specialist, and I work in Sunway Specialist Center, Damansara. What we have to remember now is that women's roles have changed. So this is in the 1950s. A woman's job was just to look after the house and have children. And women used to have children very early. My grandparents definitely did. They started having children at the age of 16. Okay. However, things have changed now. Women now wear many hats. We are not only career women. We also come home and then we have to be mummy to those who have children. Those without children have to come back and be a homemaker. We're expected to cook. We're expected to clean. We're also expected to multitask as well. And because of this, I think women are now putting off childbearing till later. So in the past, if you hit 30 and you haven't had children, you were way past your prime. But now 30 is considered young for childbearing. So what's very important is that everybody has a very different fertility journey. And this is what we'll discuss today. So when we talk about fertility journeys, this is what everyone thinks is going to be their fertility journey. So you're going to go to university or go to school, you come out, you find a job, and then you may not have found Mr. Right yet, but your career will progress. You finally meet Mr. Right and you get married and you have a family. And then after that, ding, you should get pregnant. Okay, so this is the traditional fertility journey that everyone thinks that everyone thinks should happen. Unfortunately, what you must remember is that everybody's fertility journey is slightly different. Okay, so because our fertility journeys are different, and because a lot of these milestones will happen at different stages of our lives, we're going to talk about different fertility journeys today. So what we are trying to talk about is when you meet Mr. Right and you plan to get married and you plan to have a family. So what do you do when you're trying to start a family? What can you do? So there are a few things that I advise all my fertility patients to do. And it's it's the stuff that I'm sure you all know already. So we advise you to have a healthy diet, maintain a good weight, particularly if you have PCOS. Now, I know that there are lots of women out there who unfortunately have PCOS, and PCOS patients, they tend to have irregular periods, and they tend to have a little bit of a hormonal imbalance as well. Now, this hormonal imbalance can sometimes be improved by maintaining a healthy weight. There are some patients with PCOS who are actually very slim, and weight loss in these patients may not be much use, but maintaining a healthy body mass index or a healthy weight is actually useful. A lot of my patients with, sort of PCOS, and also some of my patients, they find it very difficult to budge the weight because, let's face it, we all have busy schedules. It's very hard to fit in exercise. So actually, I do recommend, trying to, watch the calories and obviously doing a mixture of strength and cardiovascular exercise. So exercise is also very important to maintain good physical health. Taking preconception folic acid is important. Folic acid is supposed to be good for the baby's brain development and spinal cord development. And that happens in the first 6 weeks. So most people, by the time they know that they're pregnant, majority of the brain has already been formed. So the benefits of folic acid would have already, sort of passed its prime already. Getting rid of, bad habits such as alcohol, smoking. These are things that, and obviously smoking also includes vaping as well. These things obviously will improve your chances of conception as well. For those who drink coffee, there is an association with heavy caffeine usage with problems with fertility. And obviously for the men, it's time to change your men's underwear and try and stop them from wearing the tight underwear and getting them to wear looser underwear, because we want the testicles to be a little bit cooler and that's been shown to improve sperm quality as well. As supplements, now all my patients want to know what supplements they should take to improve fertility. So for the women, we do recommend some antioxidants such as coenzyme Q10 or ubiquinol. Now, ubiquinol is the active component, active form of coenzyme Q10. So this is something that you can buy from the pharmacies, no problems. Vitamin D can be taken as well. DHEA, these have been shown to sometimes improve the quality of the eggs as well. For men, you can actually try coenzyme Q10. So this is supposed to block all the free radicals that could affect the sperm. And things such as selenium, zinc, and Profertil is sort of like, it's a combination of different types of supplements, including coenzyme Q10 as well. And it's actually been clinically proven to actually help improve sperm quality as well. So these are supplements that you can try if you're trying to improve your fertility. And we do recommend taking at least 3 to 6 months of it before considering fertility treatment. Now, when you're trying to get pregnant, what is important is to know your fertile period. Now, most women have a 28-day cycle, but some women may have, longer cycles. So if your cycles are longer, you may ovulate a little bit later as well, okay? And there are some women with shorter cycles as well, so they tend to ovulate a little bit earlier. So what normally happens is that every month, on the first day of your period, the eggs sort of in your ovaries will start recruiting some follicles, and basically it's the one that grows the biggest, fastest, is the one that will release an egg. Okay, what is important to remember is that the egg only lasts 24 hours. Okay, and the sperm survives about 3 to 5 days inside. So we do advise that you start having sex sort of around your fertile period to try and improve your chances of conception. A lot of patients ask me this, so how often should I be having sex? To be absolutely honest, I think with busy schedules, with work stress, it's very difficult to have daily sex over the fertile periods, okay? So, but if you are able to do that, that's great. Your chances of becoming pregnant are about 37%. The success rates of having sex every other day actually is about 33%. So not far off actually. So I do recommend that couples try and have sex every other day. Now, if you have sex only once during your fertile period, however, your chance drops to about 15%. So I would recommend having sex every other day from day 10 of your cycle to about day 16. And hopefully we can replenish the sperm in there to wait for the egg, okay? Right, so let's talk about some cases of different fertility journeys that we do see, okay? So for example, patients, this is case 1. So this patient actually graduated and then started work, and then, during their career, they didn't find Mr. Right yet. And finally, they met Mr. Right, and they planned to get married and start a family. So what they did was they did all the right things. They decided to take their folic acid. They decided, to try having sex regularly during the fertile period. They decided to take some supplements and improve their health beforehand. But 6 months into it, they're still trying. 1 year later, they're still trying to get pregnant. And I see a lot of couples who come in like this, okay? So they're still trying to get pregnant. They haven't tried that long, but they don't really know what they're not doing correctly. So in these kind of circumstances, what I would recommend is to think about when you need to seek help. Now, age is obviously very important. We know that as the age of the woman particularly goes up, your fertility actually does decrease, okay? And it decreases quite significantly after the age of 40. It does not mean that you cannot have a child after the age of 40. It just means that it will be more difficult, okay? Which is why we do recommend that if you have been trying for more than 6 months and you're above the age of 36, that you should probably go and see a fertility specialist to figure out what's going on. Or if you're less than 36 years old and you've been trying for more than a year, perhaps it's time to go and seek help. If you're having trouble having sex, now this is something often very embarrassing, and I do have a lot of couples that come in and, you know, they will tell you that they're trying for pregnancy, and then when you ask, they're very, very shy about telling you this. But sometimes there are difficulties with erection, sometimes there are difficulties with penetration, sometimes there are difficulties with ejaculation. Okay, so these are all problems that people can have whilst trying to have sex, and if none of that happens, then pregnancy is not going to occur. Period problems. So period problems, particularly if they're painful periods might be suggestive of endometriosis. And if you have endometriosis, it might actually cause a lot of scar tissue to grow inside. And that sometimes can cause blockage of the tubes. Or if you've got irregular periods, that could be suggestive of something such as polycystic ovarian syndrome. So we know these patients have irregular periods, and very often the reason why they're irregular is because they're not releasing an egg every month. Now, what we need to do is we need to try and get this patient help early, and maybe to try and regulate her periods before she tries to get pregnant. If you've ever had cancer treatment in the past, or you've been diagnosed with cancer, you should seek fertility consultation, because what happens is, especially if you've just been diagnosed with cancer, you should be, counseled about the option of freezing your eggs, or if you've got a partner, freezing your embryos, because obviously we know that cancer treatment can affect fertility as well. Okay. How can you investigate? So in a patient, in a female patient, we've got 3 ways of assessing a female patient. So the first thing is that we look at AMH. So AMH is sort of a hormone in your body, which gives us an indication of your ovarian reserve. So how many potential eggs are left in your ovaries, okay? Another way that we can we can check your ovarian reserve is actually through what we call antral follicle count. So that means that we do a vaginal scan, and from the vaginal scan, we count the number of follicles that you have recruited every month. Now, this can differ every month. In some months, you may have less, some months you may have more. So this is something that will give us an indication of what your ovarian reserve is like. And obviously, even if you've got super eggs and super sperm, they will never meet if your tubes are blocked. And the only way that we can tell is actually to do something called a HSG, where we put a bit of dye through the cervix and we inject it in to see if there's any blockages of the tubes. Okay, so these are the investigations that you could expect for a female patient that's trying to get pregnant. There is obviously, in male patients, it's mainly to check for sperm. And when it comes to sperm, we look at 3 different things. We look at the numbers of sperm there are. We need to look at how well they swim. And then we need to look at the normal form. So we want to make sure that they're significant normal ones. In some cases, there might be lacking in either one. So if you look at these videos, you will see the difference between the normal and the abnormal. So that's normal. And if you see, that's the abnormal. Okay. So in the abnormal one, you can see that the sperm are not really moving properly. They don't look very normal, and they're not very many. Whereas in the normal, you can see there's loads of sperm. Okay. So let's go back to this fertility journey again. So this particular patient who was trying to conceive basically decided to seek fertility advice. Okay, so they went to the fertility specialist to find out what the options of fertility treatment are. So I'm going to talk about the different types of fertility treatment that one can expect to have. Now, they're all different, and they will be, they're different for everyone. And in some patients find certain things more acceptable than others. Okay, so the first thing that we can consider is ovulation induction. In ovulation induction, what happens is that we give you medications to try and encourage your eggs to grow. And this medication actually increases the natural signal from the brain that stimulates the follicles to grow. Okay. What we also hope is that sometimes you might produce more than one egg, more than one follicle, which is big enough. And if you release more than one egg, hopefully the concept is that the sperm have more targets to hit. So therefore, the success rates of pregnancy would be higher. However, if you do release more than one egg, there's always a chance that the sperm will hit more than one egg and you may have more than one baby inside. So multiple pregnancies is obviously a complication of all fertility treatments. So what we do is we give you medication, we get your egg to grow, we have a scan, see how big, the follicle is. Once we know that the follicle is big enough, then we can either give you an injection for you to bring on the ovulation, or we can just tell you that, you're going to ovulate soon, have sex during that time. So you time the intercourse around the time of ovulation, and we can make it more precise by giving you an injection to time the ovulation time. Okay, so this does improve your success rates, probably just marginally from trying normally, probably about 15%. So this can sometimes be an option, particularly in patients where like, for example, if you've got PCOS and you haven't been ovulating, or you are not actually having a period every month, this can be helpful as well to track when you're actually ovulating and making sure that you actually release an egg. There's intrauterine insemination. So this is similar concept. What we do is that we stimulate your eggs to grow in your ovaries. And around the time of ovulation, when the follicles are big enough, we give you an injection to time the ovulation time, okay? And then what we do is then we put the sperm inside the uterus, okay? So that they have a shorter distance to travel. Now, in order for this to work, intrauterine insemination, you do need a normal number of sperm. You do need to, preferably have sperm that can swim, because remember, this is like, for example, you have to get to Penang. We are only dropping you off in Ipoh. You still need to get to Penang from Ipoh, okay? So if your sperm are not able to swim, if the sperm is not very normal, if the sperm numbers are low, then your success rates are probably lower as well, okay? And this is an option. So what happens is that we tend to spin the sperm and we concentrate it, so we only find the normal ones, and then we inject it into the uterus itself. The reason why this is helpful is because about 80 to 90% of the sperm actually gets stuck at the cervical region. And so this is supposed to increase the numbers and sort of give them a shortcut. Okay. Lastly, I'm sure that everyone has heard about this. This is IVF. So IVF involves injections. What happens is that we start the injections from the second day of your period, and our aim is to make all the follicles in your ovary grow. So if you can see the ovary on the first picture here, there are loads of follicles here, and basically we give you injections to try and get them all to grow. Once they've all grown, what happens is that we will actually give you injections, two injections. One injection is to make them grow. One injection is to stop them from rupturing, so stop them from actually releasing the egg. Because once they release the egg, then you can't use it anymore, okay? And once the follicles all get big enough, we give you an injection to mature the eggs. And once the eggs are matured enough, we will do a procedure called the egg retrieval, where normally we do it under general anesthetic, so you're asleep, and we put a very fine needle through the vagina and collect the eggs. And once we've collected the eggs, we will fertilize it with the sperm. And once they're fertilized, we put the embryos back inside, at different intervals, probably one embryo at a time, if possible, and then hope that they implant. Okay, hold on there. Right, so traditional IVF just meant that we used to put the egg in the petri dish, and then we used to put the sperm in there and let the sperm do the job, okay? Let's see which sperm will swim in and fertilize the egg. So now we take things one step further, we do ICSI. So ICSI means that we actually inject the sperm into the egg. And I'm just gonna show you a video now of what we do in the lab. Okay, so if you see, we're just puncturing the egg with a very, very fine needle. This is all done under microscope. Okay, and in the barrel of the needle, you will see a sperm that has just been injected into the egg, okay? And then we hope that fertilization will take place, okay? So we're gonna go to case 3. So in this patient, she has obviously found Mr. Right, still trying to conceive, went for fertility advice, and then they tried some fertility treatments, but they've not been successful. Now, this is the most frustrating part of fertility treatment, because you kind of hope that, these treatments will help, and sometimes they don't always work. So what can we do to improve your chances of fertility? So we have two options. One of the things that we can do is IMSI, which is something that we offer in Sunway. So what happens is that if you look at the difference here, is that on the left-hand side, this is normal sperm under 400 times magnification. And on the right-hand side, in a bit, I'm going to show you, it's 6,000 times magnified, which shows you the different parts of the sperm, and it shows you abnormalities. For example, you can see that in the sperm here, they've got little small sort of dots on the head, inside their heads. Can you see? So these are vacuoles, and this might be an indication that the sperm is not very normal. So these abnormalities would not be seen if it's 400 times magnified. And the aim of this is to find the best looking sperm, so that we can use the best looking sperm to fertilize your egg, the most normal looking one to fertilize your egg. Okay, so if you see, there's a difference in the size of the sperm. Okay, right. Okay, so who should have IMSI? So patients who have very low numbers of sperm, patients who have very sort of high numbers of abnormally shaped sperm, and if you've had previous ICSI treatments with poor outcomes. So if previously we've taken your sperm and injected into eggs and they haven't fertilized, okay, we might need to see that perhaps perhaps IMSI would help you choose the more normal looking sperm. And hence, hopefully that will help with the success rates as well. So this is the embryoscope. So once fertilization has taken place, it's sort of, watching it happen. And the embryoscope is very good because it's like a CCTV to look at your embryos and see how the growth is going. If the growth is not normal, if let's say they start getting, more cells and then smaller and then they stop growing for a while, it could be an indication that perhaps the embryo is not normal. Okay, so it's quite important. This is quite an interesting technology, so that we can keep a very close eye on all the embryos to make sure that they're developing normally. What else can we do to improve your chances? So one of the things that we can consider is actually pre-implantation genetic testing. There are two types. There's PGTA, which just looks at the number of chromosomes, okay? So when it comes to PGTA, we want to see whether there is the correct number of chromosomes, whether they took extra, whether they took less, okay? The PGTM is used to actually find out specific genetic diseases. So for example, if you have a specific genetic disease that runs in your family, okay, PGTM will help us determine whether your embryo has that or not, okay? So this does improve your chances of fertility, because we know that the most common reason why embryos don't implant into the uterus is because the embryos are not genetically normal, okay? And so in that case, it will help you save time. So patients who are slightly older, it means that we will be transferring the ones which are normal, improves your pregnancy rate, because obviously we're only transferring the ones which are normal. So by right, the chances of implantation will be better, okay? And in patients with many embryos, it's always good to consider this, because, for example, if you have 7 embryos, okay, and we transfer the embryo in, okay, what you must remember is that the most beautiful looking embryo is not necessarily the one that will do the best, okay? So sometimes we are very, very superficial. When we look in the microscope, we see, and oh, okay, this one looks the nicest because the number of cells look the most, or the better ones. These ones, although we put them in, may not necessarily implant, because they may not be genetically normal. So what happens is that every time we put in an embryo that is potentially not normal, you waste at least 2 months, okay? Because it'll be 1 month to put the embryo in, and then because you don't get pregnant, we need 1 month for things to wash out, and then you try again. So if, let's say, you're very unlucky, out of 7 embryos, 4 are not normal, and we happen to transfer the 4 abnormal ones first, that means that you actually waste about 8 months, okay? So time is of the essence here. So this is something that you can consider, obviously, to improve your chances. So how do we do it? What happens is that I'm going to show you in the video is we actually take a very small sample of the cells from the blastocyst, which is the day 5 embryo, okay? And from there, we actually look at the genetic component. So we look at the DNA there, okay? Right, that's what we do. So again, like I said, patients who are older, we should consider it. Recurrent miscarriage, so patients who are having miscarriages very often. Recurrent implantation failure. So some patients, you know, they have embryos and every time we put the embryo in, it's not implanting. So then we need to figure out, is it a genetic problem? And obviously, you know, if there's a known genetic disease in your family, for example, thalassemia, it's something that you can do to screen in your baby as well. And again, like I said, patients who may have a large number of embryos, okay, you want to know which ones to put in first so as not to waste time, okay? So the last thing you want is to waste 8 months putting in embryos which are not normal before, before putting in the ones which are normal. The reason why is because every time you put in an embryo that does not implant, yes, you do waste time, but the other thing is that emotionally you feel defeated, okay? And because you feel defeated, that it's going to be very difficult for you to keep going through this kind of disappointment a few times in a row. So we're going to talk about one of the other last cases that are here. So this is a patient, this is quite common actually now, who, women now work. So this lady got her job. She has obviously progressed in her career. But unfortunately, Mr. Right is not around the corner and she hasn't met Mr. Right yet. Okay. In these and a lot of, I do see this quite a lot actually, women who sort of hit their 30s and then they find out that actually they haven't met Mr. Right. And, it's in the chances that they might meet Mr. Right later, they might decide to have children later, but it's something that they need to think about when it comes to their own fertility. So we know that your ovarian reserve actually reduces as you age. So as you age, your ovarian reserve reduces, hence your AMH also reduces as well. Okay, and because we know that your AMH and your ovarian reserve decreases, if you do meet Mr. Right at 42, then the chances of pregnancy at 42 are going to be lower than if you were to meet Mr. Right at 30. However, we can't control when we meet Mr. Right, correct? We can't control when we meet our partner that we want to have children with. And nowadays, I think it's better to just wait rather than to settle. So I think that one of the options that we can consider is actually freezing your eggs. Now, we do recommend that obviously you freeze your eggs earlier rather than later. So we do recommend that you freeze your eggs by the age of 35, okay? Reason being is because as you age, the number of abnormal eggs will increase. So in a patient who's 36 years old, remember that when we defrost your eggs, okay, only about 50% of those eggs will actually make it. So eggs don't tend to tahan the defrosting process so well, okay? Whereas embryos, we know that if we defrost embryos, majority of them will make it. So we know that in a lady who's 36 years old, you need 10 frozen eggs for a 50% chance of having a baby, okay? Now, at 39 years of age, you need 16. So the number practically, it goes up quite a significant amount as you age. So we do recommend that you actually have your baby, obviously think about freezing your eggs around the age of 35. So it's very similar to IVF. What we do is that we give you injections to freeze your eggs from day 2 of your cycle. We just want all the follicles to grow. And as they grow, and on day 5, we will scan you again. And then if they're big enough, we will give you injections to prevent them from rupturing as well. And then what happens is that we will go through the egg pickup, just as we do in IVF. Only thing is that instead of fertilizing these eggs, we just freeze them, okay? But the only thing is that sometimes if your ovaries are not functioning so well, we might need to do more than one cycle to get sufficient eggs for it to be useful in the future. Right, so I'm just going to talk about empowerment of the fertility journey. What a lot of patients must realize is that when you plan to do fertility treatment, it is actually the emotional roller coaster that comes with it that is actually very difficult. Yes, financially it's expensive, but what is very important is that you need to be strong emotionally and you need to support each other. So I think the couple needs to be on the same page and you need to get support from all angles. So I think Lumeris is really great in the sense that they give support to patients who are trying to plan for fertility. And sometimes these support groups just show you that you're not alone and that there are loads of people who are actually going through the same thing, okay? Avoid judgment. So I think sometimes people do make judgments, and I think you don't compare, don't judge, and whatever works for one person may not work for another. So be mindful of making blanket statements. So that is something that sometimes happens as well. Avoid comparisons. Now remember, what happens is that most patients will go through their fertility journey and they will actually compare themselves with everyone around them. It is unfortunate that most of the time when you're trying to get pregnant, you're going to be more aware of everyone who's getting pregnant near you. So what happens is that you will start comparing yourself with everyone else. And if you compare yourself with everyone else, you're going to become depressed because everyone's fertility journey is different. So what I always tell my patients is that wear the blinders, don't look around, and just remember that each patient actually has their own fertility journey. Now, sometimes in a fertility couple, sometimes, yes, it can be male factor. Yes, sometimes it can be female factor, but sometimes it can be both as well, okay? In these kind of cases, it's very important to support each other and to avoid blame. So don't blame. I mean, sometimes I think it's very difficult because, especially when you've got an abnormal sperm count, or if let's say you've got a low ovarian reserve, or you've got blocked tubes, it's very depressing because it's sort of your own body that's not behaving itself and that's not doing what it's supposed to do. So I think that the most important thing is to actually avoid blaming each other. Okay, and remember that, we all have our own fertility journey. What I do recommend is for all couples who are planning to get pregnant, you need to sit down together and you need to ask yourself these questions. You need to come up with what we consider a fertility roadmap. Now, the first thing you need to ask each other is, how important is it that we have a child? And how important is it that we have a child which is genetically our own, okay? Now, why I say that is because there are some couples out there that will say, no, I have to have a child which is genetically, my husband and me, okay? And that's fine. But there are some patients out there as well who say to me, actually, it doesn't really matter whose genetic material it is, as long as I carry the child. And then there's some patients who tell me that actually, if they're just going to try and get pregnant, but if they don't get pregnant, it's no big deal. They'll just adopt, okay? So this is something that you need to figure out for yourself. How important is it that the two of you have a child? And how important is it that the child has your genetic material? Secondly, you need to discuss how far will you go to have this child, okay? So for some couples, they will only consider the tablets. They will only consider ovulation induction because for them, the thought of going through injections is not what it's not something that they would consider. For some couples, IVF is against their religion, or perhaps IVF is against their own, something that they think is against nature. So I have had some patients who decide that they don't want to go for IVF. That's fine, as long as the both of you are on the same page. The most difficult sort of fertility consultations for me are the ones where the husband and the wife are on different pages. So for example, I've had cases where one part of the, one of the couple actually wants to have fertility treatment, and the other one is not willing to even consider it. And when that happens, we just end up going in circles because, both the couple are not on the same page. So it's very important for you to sit down and decide exactly how far are you going to go to have that child. Will you consider ovulation induction? Will you consider IUI? Will you consider IVF? And so basically, what fertility treatments are you willing to consider? Okay. The other thing that you need to discuss is how many times are you going to try each fertility treatment? Okay. Because although, it's important to give everything a try, you also don't want to be, trying one way. For example, you don't want to be doing ovulation induction for 10 cycles, and then later on realize that actually you've wasted your time. Okay. So you need to tell yourself, okay, maybe you need to set a time frame. When do we call it off? So for example, if you're planning for ovulation induction, you can tell yourself, okay, we'll give ourselves 3 cycles, 6 cycles. Or else if you're going to try IUI, how many cycles are you going to give a try? Okay, or if you're going to try IVF, are you going to try 1 cycle? Are you willing to do it more than once? I think you need to actually set that in your brain, set that between the two of you so that you start off with the correct sort of mentality as well. And finally, you need to think about whether you're emotionally ready and whether you're financially ready. Now, emotionally ready, because you have to remember that, fertility treatment can be so taxing emotionally, okay? It's a roller coaster, every time we transfer an embryo, or every time we put sperm into the uterus, or every time we give you an injection to make you ovulate, your hopes and dreams are on that particular treatment, okay? And when it doesn't happen, when your period comes, yes, it's going to be very upsetting, and it is an emotional roller coaster. So you need to work out, are you able to deal with these, sort of the ups and downs that come with fertility treatment? And obviously finances are important. Are you financially ready? Because, you can't sort of start, fertility treatment and then halfway say, oh, sorry, I don't have the funds, I'm going to call it off. So, that's something that you do need to prepare as well. So my take-home message is that remember, decide on your roadmap, decide between yourselves what you think you want and what you think you can have, what you think is acceptable for you. Decide when to seek help. So remember, it's very important to know when you need to seek help. I have had couples that come to see me after sort of trying for like 10 years at home. And then by the time they come and see me, it's a bit more difficult to help them because obviously having waited 10 years, your age is different. Know your options, so you know that your different options there. And yes, it is very dependent on each person. It's not a one sort of option for everyone. Everyone, so certain options may be more suitable for some than others. Ask questions. So I advise you to talk to your doctor, ask questions, and try and sort of understand the fertility journey yourself and tailor your own fertility journey, because remember that it's different for every single person. Okay. And this is a very famous picture, which I like. So I'm sure that you all know this, okay? This is a little baby, an IVF baby, that was made with over 1,000 needles from a couple, I think in the UK. And basically, this little baby is surrounded by all the needles it took to make this little baby. And so you must remember that, if you're really, if parenthood is one of the things that you really want to achieve, remember that there is no expiration date on your dreams, okay? And if it does not happen immediately, take a deep breath and remember that there is hope and you can still try again. Okay, so thank you very much.